I'm getting tired of not feeling like I'm rushing and then not getting to everything anyway. So we're just going to take it a little bit differently. All right, so Chapter 20 is all about digestive system disorders, which, with rare exceptions, are mostly chronic disorders. You know, the acute things are things like appendicitis, infection, that kind of stuff. But a lot of what we'll talk about today are kind of chronic illnesses. So the first one I'm going to cover is dysphagia. This is difficulty swallowing. There can be multiple causes for this. Neurologic deficit. The swallowing reflex is one of the most complicated in the body because it involves so many different nerves and involves both voluntary and involuntary components. So all kinds of neurologic problems can result in swallowing issues. You know, stroke can, nerve damage can. I mean, there are just lots of potential causes there. So that's a leading cause of difficulty swallowing. Muscular disorders can. The top third of the esophagus and all of the pharynx and the tongue and the cheek muscles are all voluntary skeletal muscle. So someone with, let's say advanced muscular dystrophy, for example, or somebody who has myasthenia gravis, where the muscles are weakened, that is going to cause difficulty swallowing, problems like aspiration and stuff like that. And then mechanical obstruction. Anything that impinges on the esophagus can cause difficulty swallowing, and there are a number of things that can do that, a couple of which I'll show you here in a minute. So it presents either with pain or difficulty swallowing, frequent aspiration. In the obstructions, it's often people will complain that they can only take small bites and swallow small bites. And then difficulty swallowing liquids, particularly with the neurologic deficit. Liquids are trickier than solids because solids, as you swallow the solid, it actually pushes the epiglottis down and blocks the airway. But with liquids, it's all done with muscle coordination. So in your muscular disorders and your neurologic problems, swallowing liquids is the harder part. So here are a couple of obstructive causes. Here's fibrosis. You know, say somebody has scar tissue. This can be from any number of things, including past surgery. Heart surgery sometimes will result in some esophageal scarring. Damage from hot liquids or hot foods can actually cause esophageal scarring. Acids, you know, anything that damages the esophagus, when it heals, it doesn't heal as flexibly, so you can end up with fibrosis, and obviously food is going to have a tendency to get stuck ahead of this spot that isn't as stretchy. Compression, a tumor in the mediastinum, or some aberrant vessel. You know, in other words, instead of your aorta going in front of the esophagus, in some people it goes behind, and that could impinge on the esophagus in the front, so that creates a narrow spot where food gets stuck. And then a diverticulum in the esophagus is kind of a nasty little thing. This is where the wall at some point got a little tear in it, and food can accumulate in that tear and make a kind of pocket like this. And the larger this gets, the smaller the normal passageway for food becomes. One of the other nasty things about the esophageal diverticulum is this gets to really stinking. You know, because the food that gets in here, it basically rots, so people have terrible breath. So one of the diagnoses to look for with really terrible breath that isn't resolved by teeth brushing and things like that is a diverticulum in the esophagus. And obviously this can get infected too. You know, rotting food in your nice warm esophagus is just a recipe for disaster. So this is dealt with surgically. They usually, not really surgically, they do it endoscopically now, where they'll cut this guy off and stitch it up so that there's no nasty pocket there anymore. Some other causes, this one's exceedingly rare, congenital atresia. This is where the esophagus from the top doesn't connect with the esophagus from the bottom, so it's a developmental abnormality. This obviously has to be dealt with surgically with open chest surgery to go in there and fix that. This is a fistula, In some people, again, because of a developmental anomaly, the esophagus and the trachea are connected. Now, that's a terrible idea because we want to keep anything but air out of the trachea and the lungs, but here's a connection. So these often present with chronic aspiration pneumonia because usually in little kids. You know, the kids are eating and drinking, and some of that is ending up in the lungs. So there again, this is called a TE fistula. And it makes a sort of T, which is one way to remember it. But this has to be dealt with surgically too. Neurologic damage. Swallowing involves cranial nerves 5, 7, 9, 10, and 12. So lots of different nerves involved, which means that just about anything that affects the base of the brain is probably going to have an impact on swallowing. And then achalasia, which is a very common cause of dysphagia, is where part of the esophagus doesn't peristalse right. You know, when we swallow, food doesn't like plop into our stomach by gravity. It's actually pushed towards the stomach with peristalsis. If part of that esophagus doesn't peristalse, stuff is going to have a tendency to get stuck there. It swells up, and then you end up with more and more difficulty swallowing until this area is dealt with. Now, sometimes it's removed. If there's enough, if you can stretch the top down to the bottom, they'll just cut out the part that doesn't work right. But if it's not, you have sort of a difficulty, so they might restrict this area with a band so that at least if it's not moving, the food won't collect there. It'll eventually get pushed down from subsequent swallows. So dysphagia. The real clinical problem with dysphagia is that it can lead to malnutrition and aspiration pneumonia. If it's difficult to swallow or hurts to swallow, people don't eat and drink. So they get dehydrated, malnourished, and anything that causes difficulty swallowing increases your risk for aspiration. And we talked about aspiration pneumonia last time. Anything that's not air doesn't belong in the lungs and can trigger inflammation all by itself, or infection because now there's a source. Yeah.
So you would know this pretty early on, right? This isn't something that develops later on.
Some of them do. Like this one and this one would present early on, but these guys would present later. So in your older person, this one would present after some neurologic insult. If it was neurologic, this is your post-stroke or post-spinal cord injury. Yeah. All right. Esophageal cancer, I put in here simply because it's particularly nasty. Esophageal cancer is probably one of the worst cancers to endure having. And that's because it usually affects the distal esophagus, and it creates huge problems with swallowing, lots of pain. Essentially, patients with esophageal cancer have a tendency to starve to death because the esophagus is what's affected. So it's a bad one. Poor prognosis, and that's due to the fact that by the time you catch it, it's usually well advanced and there's not much you can do about it. All right. Hiatal hernias. This is where the top part of the stomach, let's see if I have a picture good. So here's the normal anatomy, right? Here's the diaphragm that separates the thorax from the abdomen. And if you look at it, sort of from the front, if this is the chest wall here, the diaphragm sort of looks like this. It has two domes. And the esophagus comes along the back of the mediastinum, and then it punctures the diaphragm and then goes down into the stomach, which sort of looks like that. So a hiatal hernia involves this spot right here, where the esophagus passes through the diaphragm. In some people, that hole is a little bigger than it needs to be. And what ends up happening is this part of the stomach kind of pooches through and up into the thorax. So a hernia, by definition, is abdominal contents somewhere they don't belong. You should only have abdominal stuff in the abdomen. So this is a hernia because the stomach, an abdominal organ, is poking up through into the thorax. So you can either have the sliding version, which is much more common, and in this one, this little area of herniation, it can automatically reduce. So it can go from looking like this back to looking normal because the part that's going up and down or sliding is flexible enough that it can pop back down into its normal shape here. The worst kind, but the rarer kind, is the paraesophageal hernia, and this is where part of the stomach has gotten stuck up there. So it can't be reduced. This doesn't slide down, and it causes, it compresses the esophagus. It causes problems with the lower esophageal sphincter. So you might get food lodged in that hernia pouch. That causes inflammation and reflux. So whenever a patient presents with bad gastroesophageal reflux, which I know you've all heard about that, one of the things you've got to look for is a hiatal hernia, because that can be a presenting sign, is heartburn. And the nice thing is these hernias can be fixed relatively easily. I mean, it's still sort of major surgery, but and there are even some endoscopic versions of this now where they just go in with a camera, pull that part of the stomach down, and then kind of cinch up the diaphragm around here so that hernia can't pop back out. This is another, hiatal hernia is another cause for really bad breath if you've got that paraesophageal version. So frequent belching, increased discomfort when laying down. Why? Because when you lay down, the weight of your abdominal contents is sort of pushed down, and with the hernia, it then pushes up into the diaphragm. So essentially, the stomach slides up when you lay down. And then when it's impinged or in trouble, you get substernal pain. So you get, pain underneath your sternum that can radiate. All right. So GERD, we're not going to spend much time on, even though it's probably the most common GI disorder that you see in adults, is gastroesophageal reflux disease. And we've all heard about this. But this is where contents of the stomach, let's go back to our stomach picture, contents of the stomach get, reflux just means to go backwards. So they sort of gurgle up into the distal part of the esophagus. And because the esophagus doesn't have any acid protection, it causes heartburn. And it's not the heartburn that's bad. The problem is the distal part of the esophagus actually starts to get eaten away by the stomach's acid and enzymes. So you can have erosion. That erosion leads to inflammation, which tends to make the reflux worse because now that lower esophageal sphincter that's supposed to keep the esophagus closed is inflamed, and it relaxes and causes more trouble. So often seen with hiatal hernia. Delayed gastric emptying can be a factor. In other words, if your GI transit is slow, high protein, high fat diet, for example, things move real slow through the digestive tract, that can lead to GERD. And then a number of substances are known to cause that lower esophageal sphincter to relax. So just as a little anatomy review, since it's already on the board. So at the top part of the esophagus and at the bottom part of the esophagus are two places that act different. They don't look different, they're not anatomic, but they act different. And we call that the LES, or lower esophageal sphincter. When not swallowing, the LES stays tightly closed in the normal person. But in the presence of some of these, or all of these substances, that lower esophageal sphincter relaxes, which allows acid from the stomach to go backwards and then cause heartburn. So many of us have probably experienced this, but caffeine, fatty, spicy foods, alcohol, smoking, certain pharmaceutical drugs, you could add chocolate to this list, all of those relax the LES and then trigger gastroesophageal reflux. Just as a side point, we used to have a medicine that actually helped close that LES. It was called Reglan, only Reglan ended up having problems in other parts of the body, so we can't use that anymore. So we don't really have a medicine that works at the LES. So we don't have a medicine that targets the problem. Instead, we have medicines that will reduce the acid in the stomach by blocking the proton pump that creates it. So like your Prilosec, for example, it doesn't fix the reflux. You still reflux. It just doesn't hurt because it's less acidic. So that's sort of current treatment for GERD. All right. Peptic ulcers. These peptum or peptic is just of the stomach or of the acid. Technically speaking, it's of the acid. So people end up with ulcers in two places. In the stomach proper. I'll just continue my little picture here since I'm drawing the digestive tract. In the stomach proper or in the duodenum. So remember the three parts of the small intestine: duodenum, jejunum, ileum. The first part of the small intestine is the duodenum, and it gets substance or chyme, which is what we call what's in the digestive tract, directly from the stomach, which means that the duodenum sees a lot of acid, right? Because the stomach contents are very acidic, and that acidic stuff empties into the duodenum. So the two places in the body that are most susceptible to acid burning are the stomach and the duodenum, and sure enough, that's where we see most ulcers. So the most common of the peptic ulcers are not in the stomach. Everybody thinks they're in the stomach, but no, it's the proximal duodenum is the most common site for ulceration from acid or peptic ulcers. They can also be found in the stomach. They can even be found more distal in the duodenum, but now you're into pretty rare stuff. So in order to understand ulcers, you have to understand the normal. So normally, the inside lining of the stomach is protected by a thick layer of alkaline mucus, you know? So the stomach makes acid, and it has to protect itself from its own creation. So in the stomach, we have this thick layer of mucus. In the duodenum, we have a thick layer of mucus, and we have the pancreas, which is right here. Looks like a little bit like a fish. And the pancreas produces bicarbonate. Bicarbonate neutralizes acid, right? So that's part of the duodenal defense mechanism. So ulcers happen when the acid base, or when the acid and protection from acid balance gets thrown out of whack. So one of the most common causes is a decrease in that gastric mucus that protects the stomach. Because many of the NSAIDs, you know, like ibuprofen and naproxen, medicines like that, they reduce the formation of that mucus in the stomach. Classic side effect. Not what's intended, but a secondary effect of those chemicals is to reduce that mucus layer. If you take that away, now the acid can get to the wall of the stomach and start eating it away. So that's the relationship between NSAIDs and ulcers. One of the few contraindications for those non-steroidals is a history of peptic ulcer disease, because it will trigger a recurrence of those. Let's see. And that mucosal defense problem, those are usually gastric ulcers, not duodenal ulcers.
Don't they have NSAIDs now that are like a mix with an NSAID and then so are those contraindicated too?
No, those are trying, because a lot of people need NSAIDs chronically, but it's chronic NSAID use that leads to this. So they're trying to figure out a balance. Like, that's one of the reasons the COX-2 inhibitors were invented. There are NSAIDs that don't do this, that don't affect the gastric mucosa. But then there are also medicines you can take that increase the mucus production while you're taking the NSAIDs. Yeah, like a combo. So that's gastric ulcers, are usually a decrease in that mucus. Duodenal ulcers, which are the common stress ulcers, they come about because of an increased acid production. Turns out part of the stress response that we learned about is an increase in acid production in the stomach. Why? Maybe to get us ready to eat the thing that we're fighting or fleeing from? I don't know. But the bottom line is the stress response increases hydrogen ions, which then makes it more difficult for the duodenum to neutralize that acid quickly. So the treatment for duodenal ulcers is usually acid reduction, you know, like Prilosec or Zantac or Prevacid. All right. Let's see. Another cause of a decrease in that mucus is an inadequate blood supply. So in order to create mucus, you need to have a good blood flow. If you are in a state of vasoconstriction, so stress will do this, smoking, circulatory shock if you're sick for some other reason, that mucosal barrier starts to break down because of a lack of blood supply. In addition, that inadequate blood supply gets in the way of that epithelium turning over. No part of the stomach lining is more than a week old, but that means it needs a vigorous blood supply to support all that cell division. So I'll show you a picture of stress ulcers here in a minute that we talked about in the cardiovascular system. Direct result of vasoconstriction. When the stomach gets starved for blood, the mucosa breaks down and you get ulceration. Glucocorticoid use increases the risk for ulcers as well. And then we already talked about NSAIDs. Alcohol also breaks down that mucus layer, which is one of the reasons why alcohol overindulgence results in vomiting, is it irritates and breaks down that mucus layer, so the stomach gets irritated and tries to evict the poison. All right.
What are the long-term effects of that, like chronic use?
Of what?
Alcoholism, because you don't, I guess patients that I know, use alcohol all the time.
Mm-hmm.
I don't notice that they have stomach problems right off. That's the first thing I'm paying attention to. So is there
No.
a long-term?
There is. Long-term, it causes gastric atrophy. So the mucosa of the stomach basically stops doing its job very well and it gets thinner, which puts them at higher risk for things like perforation, where an ulcer actually goes all the way through the wall. But it's mostly atrophy. Yeah. So there's mucosal barrier problems, right? There's acid overproduction problems from stress. And then another set of risk factors or causes for these ulcers are an increase in not only acid, but also pepsin. So anything that increases gastrin levels or vagal stimulation, you're not only going to produce acid, but pepsin as well. Pepsin is a proteolytic enzyme, and it will take a acid ulcer and make it a big, nasty ulcer because it'll actually break down the wall. Yeah.
How do all these affect the absorption in the stomach? Because what do we absorb in the stomach? Feed?
No, you're thinking of intrinsic factor, which is made in the stomach, but it's absorbed in the terminal ileum.
So
there's very little absorption of anything in the stomach. The only thing that comes up about that is alcohol and aspirin are absorbed from the stomach, but they're the exceptions. Nothing else is.
So does the stomach, I'm thinking of intrinsic factor, does the stomach still produce that with all these problems, or no?
Well, its ulcers don't affect that, but the gastric atrophy we were talking about, it can lead to vitamin B12 deficiency, which is why that's often a test that's done on the alcoholic, because their stomach is atrophied, they're malnourished anyway, their diet is crap, and their B12 is low because they're deficient in intrinsic factor. Yeah. All right. Let's see. So there again, anything that increases stomach acid secretion. So here's some of our favorite foods again, and substances there. All right. So complications for ulcers, hemorrhage. When you break through that mucosal barrier, it's going to bleed. Those blood vessels are supposed to be protected from that acid by something, and they're not. So it's the most common complication is bleeding, and it may be the first sign of a peptic ulcer. Now the problem is blood in the stomach is hard to find. Unless you're vomiting it up, by the time it makes its way through the whole digestive tract, it's going to be hard to tell that it's there unless there's a lot of it. So one of the causes for occult blood, a small amount of blood in the feces, is from hemorrhage in the stomach. Perforation, this is where the ulcer eats all the way through the wall of the stomach. So now you're going to have a peritonitis, because now stomach acid and proteolytic enzymes are in your peritoneal cavity, which nothing should be there except a small amount of slippery fluid. And you can actually end up with stomach contents in the abdomen too, which is not supposed to be there. So this is a medical emergency. Perforation of any part of the GI tract is going to cause massive inflammation, shock, circulatory collapse as the body tries to attack all this stuff that doesn't belong. So it is always a bad thing when GI contents get somewhere they're not supposed to be. And then a very rare one would be obstruction. Bad peptic ulcers, gastric ulcers, or duodenal ulcers over time might cause enough scarring that the tube constricts shut. So the duodenum, closes, or even the stomach itself gets so scarred that nothing can get through. And that's going to cause a malnourishment. All right, so what do these look like symptomatically? Epigastric burning. So people usually point right at their sternum. And it usually follows stomach emptying and is relieved by food, which is sometimes counterintuitive to people. Well, when we're eating, doesn't that mean that we're making more acid? Shouldn't it hurt worse? No, because when you start to eat, the pH in your stomach actually goes up. In other words, it's less acidic on a full stomach than an empty stomach. So the highest acid time is before you eat, not while you're eating or during eating. So people will say that they eat to make their stomach pain go away, and that's a classic peptic ulcer history. Diagnostic tests, the one that's done all the time now is endoscopy. It's called an EGD, an esophageal gastroduodenoscopy. So they basically take a camera and they look at the whole esophagus, they look at the whole stomach, and they make the bend and they look at the first couple of parts of the duodenum, looking for those ulcerations. And then treatment, proton pump inhibitors, that reduces the acid produced by the stomach. And then we have to talk a little bit about H. pylori. Helicobacter pylori is a bacteria that is very strange because most bacteria die with acid. They don't live in acid, so the acid kills them. This one loves acid. It thrives in very low pHs like you find in the stomach. And the problem is it irritates the lining of the stomach, which reduces that mucus secretion, and it can lead to peptic ulcers. So whenever you have a peptic ulcer patient or a patient with chronic GERD, gastroesophageal reflux, they're now tested for this Helicobacter pylori. If they find evidence of it, then you'll be on a course of antibiotics. Usually it's azithromycin. And this bug is kind of hard to kill, so patients sometimes have to be on antibiotics for months, for 6 weeks to 3 months to rid themselves of this H. pylori. Once you get rid of it, though, a lot of times your heartburn or your ulcer problem goes away. So it is, nobody's sure exactly how this bug makes this problem. There's just been a cause and effect determination, that if you have H. pylori, you're at increased risk for peptic diseases, and if you don't have it, you're at decreased risk. So we attack the little H. pylori bug. All right. And then, of course, reduce the exacerbating factors. Reduce stress, reduce smoking, caffeine, those LES dilators. All right. So stress ulcers are a form of peptic ulcers, but they occur as a result of severe trauma or systemic problems. So, we talked about cardiovascular shock the other day, and how in the body's attempt to maintain a blood pressure, it causes massive vasoconstriction all over the body. Well, one of the sites that's affected by that is the lining of the stomach. So this is what it's supposed to look like, sort of wet and shiny. All these little guys, those are all stress ulcers. So if you wanted to make up a story about this stomach, you could say this was an otherwise healthy 25-year-old who was in the ICU for several days for meningitis, had massive circulatory failure, was on a lot of pressors, so a lot of drips to keep the blood pressure up. He died, and then on autopsy, these stress ulcers were found. Because this is what you get when there's inadequate perfusion. In other words, when the blood pressure is so low or the vasoconstriction is so high that blood can't get everywhere that blood needs to get. So these are little areas of dead gastric mucosa. Now, if this patient had lived, any one of these may have resulted in a perforation. So sometimes the patient gets better only to then get worse again when one of these ulcers, ruptures and causes a hole. So those are stress ulcers. It's one of the reasons why we make patients NPO and we don't put anything in their stomach when they're in cardiovascular collapse, is to try to reduce the workload on the stomach so that they don't have that problem. All right. Pyloric stenosis, near and dear to my heart because it's totally a pediatric problem. The pylorus is the last part of the stomach. So if the stomach is kind of a J like this, it ends in a kind of funnel right here. And then right here is a real strong part. The whole stomach is smooth muscle, right? But here there's a thickening of that smooth muscle that forms a sphincter called the pyloric sphincter. Well, in pyloric stenosis, this muscle is too big, it's too buff for the little tiny stomach of the child. So you end up with just this little tiny gap like this, and that's all that's, food has to pass through this little tiny stenotic valve. So we see this, and this is a weird history thing, but pyloric stenosis is most common in firstborn males, which is a very strange thing, because why would it matter? Why would firstborn matter? The numbers say it matters. So it's usually boys, firstborn, and it's projectile vomiting. Now, a lot of parents, who are particularly if this is their first child, will call a lot of vomiting projectile. But the pyloric stenosis child is the master of projectile vomiting, as in feet across the room shooting out. And that's because their little bellies fill up with milk, but the milk can't get out of the stomach because the pylorus is so tight that nothing can get out. So it backs up in here, the stomach gets angry, contracts, and evicts the milk out. So these kids are hugely hungry because the food is not getting into the part of the intestine where it can be absorbed. So they're massively hungry, but they eat and then vomit and eat and then vomit. So until it's caught, the infant fails to gain weight, they get dehydrated, they're some of the maddest babies ever because they're just so hungry they can't even see straight, so to speak. And then on exam, a lot of times you can feel the olive. So if you feel in the upper part of their bellies, you can feel this little hard, roundish, like an olive thing, and that's that hypertrophied pylorus. So surgery is required. They cut some of this pylorus out so that then the milk can get through. You can get it later in life, your book says, although I've never encountered that. But you would have vomiting and apparently fullness too. But the common one you see on boards and stuff is pyloric stenosis, firstborn male. It's one of the causes for failure to thrive in the first 2 to 4 weeks. So pyloric stenosis. All right.
So if they don't do anything about it, and obviously they're not going to gain weight,
the baby will die if you don't do anything about it.
So they're not getting any nutrition at all whatsoever.
None.
Like,
not even water. I mean, they get dehydrated even.
Right, but none of it's going through there at all.
I mean, I'm sure it varies. There's probably different levels, but not enough to have the baby grow, and they end up dehydrated, which says that it's not even water is getting through, like not even the liquid is getting through. So yeah, it's the surgery is usually done right away. As soon as it's diagnosed, they schedule them for the next day.
My cousin's son they call it ESE, I want to say, is what they call it, and I've never heard of it, and so I looked it up, but he is 2, and since he was little, he always is thrown up, it doesn't matter what he eats, how much he eats, he throws up. He's
ESE?
I think, almost positive that's what it's called. It's esophageal something, I don't remember, but he can't keep anything down, anytime he eats, which would be half of the cheeseburger, he throws it up, he throws up everything, every time he eats, and they can't, they're not, just keep sending him in for allergy tests, but
they think it's eosinophilic esophagitis, EE. I bet that's what they're thinking.
But he don't know. I mean, he's not even on the charts for his
yeah. Pediatric GI is just really tough because you'll see 20 kids that have, you know, exactly what you'd expect to have, but then every day there's some kid like that doesn't fit any of the books, and you're like, what on earth? And all you can do is just, you know, try stuff or guess, you know, or keep testing until you find something. They're real bears. I think it's some kids' GI tracts and brain just don't communicate very well, you know, and you get stuff like recurrent vomiting. Yeah, that's bad.
Well, I told her, I mean, she was told to give him fatty foods. Like, he's supposed to eat, like, chicken nuggets and french fries. Like that's what he's supposed to eat.
Because he's taking in so little. Yeah.
Yeah, but I mean.
Yeah, it can be a real hassle. Hopefully you won't end up on liquid feedings, because that's one of the next steps with that kind of thing. Okay, did everybody answer the enter your student number question? Oh, no, because I didn't put it up, did I? All right, so let's do that first. Oop. And so put your student numbers in. And then while you're doing that, you can get ready for this question. Which of the following symptoms suggests the presence of a hiatal hernia? Seven, 8, 9, 10. There's 9. I got 2 more I'm waiting for.
My phone is dead.
Oh, so we're -1. You can write that down so I don't ding it. Irish here. Okay. All right, that's everybody then. So, this is a question. Okay. Now you should have the question. All right, good. That's B, heartburn. When you think hiatal hernia, think heartburn, because it's a leading cause of persistent, recurrent gastroesophageal reflux disease. Now, do you get some abdominal pain like when laying down? Yes. Cramping? No. There's not. The part of the stomach that ends up slipping through that hole isn't a part that's really vigorously contracting. That would cause cramping. Abdominal cramping is usually intestinal, because that's where the all that motion is taking place. All right, so epigastric pain relieved by food is suggestive of which of those things?
So just to be 100% clear, the slides that you skipped, like gastric cancer, won't be on the test?
I'm going to post the shortened one, and anything in the shortened one is game on the test, even if I don't get to it. You know, like last time I didn't get to all the stuff, but the rest of what was in that shortened set is still fair game.
So this is not the short set?
No, this is the short set.
Okay, so like you skipped gastric cancer, sleeping prostate.
Yes, yes, and I'm going to post, and I'll make it clear when I post it exactly what I mean.
Okay.
All right, so the answer here is C, gastric ulcer. And this is one of these, you know, when it comes time, you're studying for boards and all that, and you've got all of these illnesses that you've heard about, all these pathologies, and it's hard to keep things apart. This is a classic one for gastric ulcers, and usually the writers of the tests try to give you at least a few little hints like that, where it's like if you remember one thing about gastric ulcers, and that is it's relieved with food, you know, it's a pocket fact. So abdominal pain that's relieved with eating is usually a gastric ulcer. All right? Okay. All right, so from the stomach to the liver. Gallbladder disorders, very, very common. And one of the problems with these It's that the different kinds, it gets confusing because they each have a different name. So we'll go through each one of these. So cholelithiasis, lithos is stone. So, and chole is bile. So this is having bile stones. So a lot of people have gallstones. Just having them is not a disease, is not a problem. It's when those stones go on to do something else, that's where the pathology arises. So cholelithiasis all by itself is not something you have to deal with or do something about. These come about because bile has all kinds of stuff in it, and in the gallbladder, the water is removed from bile to concentrate it, and in that process, sometimes there's precipitation, just like you have done in the chemistry lab. You put two things together and something appears in the beaker. Same thing happens with cholelithiasis. So there's precipitation from bile. Cholecystitis is inflammation of the gallbladder or the cystic duct. This can be from any cause. This can be from infection. This can be from autoimmune. This can even be from trauma. So cholecystitis just means inflammation of the gallbladder. Cholangitis. This is where the ducts that carry bile are inflamed. So this is usually infectious in origin. But if cholecystitis is gallbladder, cholangitis is bile ducts, the ducts that carry those things around. And here's a fun one to say. Choledocholithiasis is when a cholelithiasis has gotten into a duct, and is causing an obstruction. So this is obstruction of the biliary tract by a gallstone. Choledocholithiasis. So gallstones usually form in the gallbladder, and the problem arises because of how the various ducts of the GI tract are arranged. So you've got, here's your liver, obviously. The liver has the hepatic duct, so the right and left, right and left bile ducts join to form the hepatic duct. The hepatic duct becomes the common bile duct when the cystic duct from the gallbladder joins. And then the common bile duct joins with the pancreatic duct to empty into the duodenum at the sphincter of Oddi, or the major duodenal papillae. So, a stone from the gallbladder can clog up anything in here. So it can get lodged right here and block bile from both the gallbladder and the liver. That's going to cause jaundice as the bile backs up into the body. That stone can get lodged right here or right here and block both the pancreas, the gallbladder, and the liver. That can lead to a pancreatitis, a hepatitis, and a cholangitis, and a cholecystitis. So in the if you had to redesign the human being, it would be smart to have the common bile duct enter the duodenum in one place and the pancreatic duct in another. But that's not how it happens. So we have this one shared duct for both the pancreas and the biliary system. So these stones can lodge in any of these places. They can even appear in the liver themselves because these gallstones can precipitate in the biliary tree of the liver. All right. So gallstones vary in shape and size. They can form anywhere there's bile. They consist usually of cholesterol and bile pigments. The bile is bright neon green. I can prove that to you in the cadaver lab. It's a very strange color. And the reason for that color is because of the bilirubin or biliverdin, the breakdown products of heme from hemoglobin, together with calcium salts, and you end up with stones. So small stones might not do anything. Giant stones may also not do anything, because if they're giant, they're too big to get out of the gallbladder. The ones you have to worry about are the large ones, big enough to block something, but small enough to actually move around in the system. All right. Risk factors. Women much more likely than men to develop gallstones. High cholesterol is a risk factor. Obesity, multiparity, oral contraceptive use, and then anything that challenges the liver. So hemolytic anemia, we'll talk about that in a minute. Cirrhosis or biliary tract infection. So this one isn't politically correct, but the classic gallstones mnemonic is FFF. So it's female, 40, fat, and fertile. Those are the 4 F's of gallbladder disorder. So typically, gallbladder, people that have gallstones fit into all 4. It's not one of those. It's usually all 4 is the highest risk factor. All right. So we'll take that off so Sister Mary Ann doesn't walk down the hall and see that. So when a duct is obstructed, you get basically crampy pain, so waves of pain as the ducts are trying to push that stone away. Nausea and vomiting. Jaundice will eventually develop as the bile backs up into the liver and then into the blood. The gallbladder can rupture if the obstruction is after the gallbladder. And surgical intervention can be necessary to basically take that gallbladder out. Much easier surgery than it used to. You know, it used to be removing a gallbladder was open abdomen surgery. Now they do it through a little tiny, 2-centimeter incision. They basically take it off the liver, they put it in a little bag, they grind it up, and they slurp it out, is how it's done now. All right. Let's see. Okay, so jaundice. Jaundice is a buildup of bilirubin in the blood for any cause. That's jaundice, is the buildup, the elevated bilirubin. We divide jaundice into 3 categories based upon where the problem is. So prehepatic jaundice means that the problem is before the liver. And in this case, it's excessive destruction of red blood cells. Bilirubin is created when red blood cells die. Now, normally, red blood cells die at a rate that the liver can very easily keep up with. But if there are lots of red blood cells dying, like from a sickle cell disease or from a massive trauma can do this, particularly crushing injuries, there is too much bilirubin for the liver to dump into the bile to get rid of in the intestine. So we have a jaundice, a backup. And intrahepatic jaundice, this means that the problem is inside the liver. So the liver is either not making or is not getting rid of bilirubin, or that bilirubin can't get out. So we see this in liver disease. So hepatitis, cirrhosis, anything that damages the liver will cause jaundice because the liver's not doing its job. In other words, it's not putting that bilirubin in the bile where it belongs. And then post-hepatic jaundice, the liver has put the bilirubin in, but the bile can't get anywhere. So this is like an obstruction of bile flow like we were just talking about. A tumor, cholelithiasis, eventually jaundice will occur. It's not in the liver and it's not ahead of the liver, it's after the liver. So it can't get out of the biliary system. So here are just those 3 causes. So in the prehepatic, hemolysis is elevated and bilirubin goes up because the liver can't keep up. In intrahepatic jaundice, it's the liver itself that's not producing enough bile to get rid of the bilirubin. And then post-hepatic, the liver is making it, but there's no, it's not getting into the digestive tract to be gotten rid of. All right. Hepatitis is just simply inflammation of the liver. It has many causes. So alcoholic hepatitis, alcohol is metabolized by the liver, and some of its metabolites are toxic, so it actually damages the liver, leads to a fatty liver. Idiopathic hepatitis, that just means its cause is unknown, but it leads to the same thing, fatty liver. Viral hepatitis, this is your hepatitis A, B, and C, is a viral infection that preferentially attacks the hepatocytes. And then infection in other parts of the body can also lead to a hepatitis, like mononucleosis. Usually the liver is involved and gets kind of swollen and tender. or amoebiasis from amoeba ingested. And then there are lots of chemicals and drugs that will directly cause a hepatitis. Remember, the liver is the great detoxifier of the body. So toxins have a tendency to hit the liver hardest because that's where they're being dealt with or addressed, is in the liver. So just as an example of a viral hepatitis, you're exposed to the virus. Hepatitis B is bodily fluid contact, usually blood-to-blood contact. So you get acute infection, which leads to some jaundice. In most people, they recover, but in some people, that icteric stage or the jaundice stage where the liver is sick, they may go on into a chronic infection and eventually liver failure or death. If the patient's immune system is weak, that icteric stage can result in a fulminant infection. In other words, the liver is literally dying from the virus, and that'll result in death. And in some people, they don't get the acute infection at all. Instead, they just become an asymptomatic carrier. So they're positive in terms of antibodies. They can transmit the bug, but they don't have any active hepatitis. The only defense we have against the viral hepatitis is vaccination, because it's quite penetrant. In other words, most people who are infected end up with disease, at least in the acute phase. So it's one of the reasons why we start the hepatitis B vaccine either at birth or before the child goes home from the hospital, or at 2 months. All we can do is supportive measures. And interferon. Interferon has been used. It decreases viral replication, but it's not very effective. It's not effective in very many people. All right, so not a lot of, unlike HIV where there's lots of treatments available, hepatitis not so much. Toxic or non-viral hepatitis, you see these, I mean you really do, particularly this first one. Acetaminophen overdose attacks the liver. And if you take enough acetaminophen and don't get help, your liver will fail. You'll die of liver failure. So it's a kind of strange overdose to take care of and watch because, the person tried to commit suicide tonight, but they're not going to die for 6 weeks because it takes that long for the liver to fail. But it's an absolute. If you take enough acetaminophen and you don't have the detoxification drugs given, you will die of liver failure. And then these others are much less common. Carbon tetrachloride, see that ethanol. Obviously, ethanol leads to cirrhosis, which we're going to talk about in a minute. All right. So cirrhosis is the toxic effects of alcohol on the liver. And there again, why the liver? Because it's the liver that turns alcohol into non-toxic or non-bioactive substances. So another name for cirrhosis is alcoholic liver disease. There are other kinds of cirrhosis, though. Cirrhosis technically just means replacement of normal liver tissue with scar tissue, non-functional fibrous tissue, or fibrosis. So there are other causes for that, but the alcoholic version is the most common. So we get extensive diffuse fibrosis. Essentially, the liver hardens. And once the liver hardens, blood can't pass as easily through it, and it stops doing its jobs. The liver has lots of jobs. One is to make bile. Another is to make plasma proteins, clotting factors. The liver is a very busy place. So it's these two things. It's the destruction of liver tissue and the interference with blood supply that really results in most of the symptoms of cirrhosis, like portal hypertension, like esophageal varices, and things like that. It's diagnosed by biopsy, and then serologic testing, in other words, blood testing, to determine how well the liver is working today. So once you've made the diagnosis, you want to find how much damage has been done. So initially is the fatty liver stage. The liver is enlarged. It's asymptomatic and reversible. So this is the young alcoholic. The young alcoholic has changes to his or her liver, but those changes are reversible, but he or she doesn't know that there are changes to the liver. So this is where we could intervene medically, not medically, but we could intervene behaviorally, but a lot of times we don't know it's there yet. Second stage is that alcoholic hepatitis. So you have inflammation, and now you're getting necrosis. Once stuff starts to die, it usually doesn't grow back right. So when those liver cells start to die, they're replaced by fibrous tissue, and then we're heading towards end-stage cirrhosis, where most of the liver now is fibrous tissue, not functioning liver tissue. So we have a backup of blood, and then liver function failure. So it stops doing what it's supposed to do, like making bile and plasma proteins and things like that. All right. So some of the functional losses, bilirubin builds up because it's the liver's job to put bilirubin in the bile. Decrease in bile causes problems with malabsorption, particularly with fats. A decrease in the clotting factors makes for easy bleeding and prolonged bleeding. It's the liver that manages our glucose-glycogen balance. So like between meals, it's glycogen from the liver that's used to power the brain. Excuse me. Ooh, that was a big one. So when the liver starts to fail, that fails and it leads to hypoglycemia. And the liver inactivates things. So like medications, hormones, things like that. So basically it's all, if you remember all the things the liver does, cirrhosis starts to shut all those things down. All right, we're going to skip some of this stuff because we've done all that. One of the biggest problems with cirrhosis of the liver is portal hypertension. And just as a reminder, the digestive tract has kind of a strange venous drainage compared to the rest of the body. You know, normally we go from artery to capillary bed, and then back to vein, right? Well, in the digestive tract, it goes artery, capillary bed at the intestine here, and then we go to the portal vein, which goes to the liver, goes back into capillaries again, and then ends up in a vein. So when the liver is clogged, you know, when it's fibrous, it's hard for blood to pass through it. So what we end up with is a backup. Blood backs up in front of the liver, and we get portal hypertension. So like the veins that would normally drain the stomach, which are seen here, they get bigger and the blood flows through them slower, so they get all engorged. And some of those veins wrap around the esophagus right here. So one of the common causes of death from alcoholic cirrhosis is ruptured esophageal varices. So a varice is just a dilated vein that's present around the esophagus, the result of portal hypertension. You add that to some gastroesophageal reflux and ulceration, and you can end up with a massive bleed into the stomach. So this is the patient that literally presents vomiting buckets of blood. It's usually an esophageal varices, and it's a direct effect of cirrhosis causing a backup of blood into the portal venous system. All right. Other things you see as a result of that backup, impaired digestion and absorption, because blood can't get from the digestive tract through the liver, so fluid builds up in there, everything gets all boggy and edematous. Ascites develops. The end-stage alcoholic cirrhosis has an even bigger beer belly than they had before, and that's because their abdomen is literally full of fluid called ascites, which, how do you tell the difference? It's how it sounds. In ascites, it sounds like a drum because it's all fluid, and if it's just a beer belly, it has sort of a softer sound to it. All right. We're going to skip that. All right. I'm not going to go over this, but this is a table right from your book. The liver, because the liver has so many jobs in the body, when it goes bad, there's symptoms all over the place. You know, there's all different kinds of things that go wrong, but you can trace them all back to things that the liver does normally, that it's supposed to do. So this list kind of goes through the common signs and symptoms that you see in liver disease and tells you how is the liver responsible for that. So for example, generalized edema. The patient in advanced liver failure, they're edematous. And the reason for that is the liver is no longer making albumin. Albumin is a plasma protein, and it plays a major role in colloid osmotic pressure, like we talked about, pulling fluid back into the vessels. So without that, they end up with leaky vessels that end up causing edema. Liver cancer, the most common is hepatocellular carcinoma, and this is a primary tumor of the liver. This is sort of what it looks like. You know, here's normal liver tissue over here. This is a giant tumor, and this is a little metastasis of that tumor. The other thing with the liver and cancer, the liver gets a huge amount of the cardiac output. You know, it's like 30% of the blood that the heart pumps ends up going through the liver. And the liver has lots of little nooks and crannies. So it's a very common site for metastases from anywhere. Could be from breast cancer, colon cancer, ovarian cancer, cervical cancer. Because so much blood passes through the liver, it's a common spot where tumor cells get lodged and start new tumors. You know, the lungs are a little bit like that too. In cancer, you can live without a whole liver. You can live with just part of a liver. So a lobectomy is very common. Ablation, trying to destroy the tumor. You can stand to lose quite a bit of liver before you actually have clinical problems. So the goal here is to try to get rid of the tumor and leave you with enough liver that you can survive. All right, so that's liver stuff. Hepatitis, a little bit of cancer stuff, portal hypertension. And I think what's going to be our last topic here tonight is the pancreas. So just as a refresher, the pancreas has two jobs in the body. One is to make enzymes for the digestive tract, enzymes that break down all of the different things we eat. The pancreas is the only place in the body that can produce carbohydrate busters, protein busters, and fat busters. In other words, can break down all three of those things. So given that function, when the pancreas gets sick, it has a tendency to digest itself because one of its jobs is to make enzymes that digest carbohydrates, proteins, and fats. Well, what is the pancreas made of? Carbohydrates, proteins, and fats. So normally, the pancreas secretes enzymes that are inactive, and then they're activated when they get into the duodenum. But when it's inflamed, it produces active enzymes, and we end up with autodigestion. So pancreatitis is particularly nasty because of the enzymes that it contains. So it's not just a typical, swelling. Literally, the pancreas and the surrounding tissues start to get digested, torn apart. So you end up with these very large areas of extensive necrosis because the cells and the tissues have been just destroyed by the pancreatic enzymes. So acute pancreatitis is a relative medical emergency. That all that necrotic tissue, you get widespread inflammation, massive circulatory shock. So hypovolemia, pale skin, all the classic signs of shock. So what are the signs? Severe epigastric pain, usually radiating to the back. So sometimes the pancreatitis person will come in holding the small of their back saying, oh, my back hurts, my back hurts. And that's because the pancreas is actually behind the abdominal cavity. So, and it's severe pain. Signs of shock from hypovolemia, low-grade fever, until the infection develops. So initially, the inflamed pancreas is just digesting itself. Eventually, though, that soup of necrotic, dead, digested cell parts is going to get infected, and then you have an infectious pancreatitis. So on exam, you'll have abdominal distension. When the pancreas is sick, the whole abdominal or the whole digestive tract just shuts down. So you get distension, you get decreased bowel sounds, decreased peristalsis. So there are lots of things that can lead to pancreatitis. The common board type question is alcohol consumption, particularly in the chronic alcoholic. Alcohol consumption can trigger pancreatitis. Those enzymes activate inside the pancreas. The pancreas digests itself. We get a lot of necrosis and inflammation. That leads to shock, DIC, ARDS. All these things are bad things, right? These are all ICU level bad things. And then over here, those enzymes end up in the peritoneal cavity, so we get severe pain, hemorrhage, shock, peritonitis, hypovolemic shock. So the take-home message there is pancreatitis is bad. It needs to be taken very seriously. The treatment is, if it's infectious in origin, it'll be antibiotics, surgical intervention to try to contain this catastrophe that's happening in the retroperitoneal space. But it is a thing that can kill you because you can't live very well without a pancreas. So it's not like they can just go in and take it out. They have to kind of control the damage, essentially. It's a classic medical cure most of the time. In other words, there is no surgery that's done. It's all supportive care. Keep the patient alive and wait for the pancreas and the surrounding tissues to heal. All right. I think we did all those things. In terms of diagnosis, which, anybody who's working in a triage setting, like an ER, the best thing to get in terms of to determine if it could be a pancreatitis is a serum amylase. Amylase is one of the enzymes that the pancreas makes. It's not supposed to be in the blood. It's supposed to go into the digestive tract instead. So if you have a serum amylase level, that's usually a sign of pancreatitis. So it rises first, but then it falls after 48 hours as the pancreas starts to destroy itself or be destroyed. It can't produce the amylase anymore. Lipid levels are high, hypocalcemia, and usually there's a big healthy white count as the body responds to this retroperitoneal catastrophe. All right. Pancreatic cancer, I put this one in because of this last line. Mortality is close to 95%. Pancreatic cancer is one of the deadliest cancers that there is. Risk factors, smoking, past incidents of pancreatitis. It's usually an adenocarcinoma. You get a lot of weight loss and jaundice early on, but the problem is it's usually asymptomatic until it's very well advanced. So pancreatic cancer is particularly nasty kind. All right. Some questions, then we'll call it a night. Elevated serum, lipase, and amylase are indicative of which of those things? Good, most of you got that. That's pancreatitis. We talked about the amylase, but lipase is also one of those enzymes that the pancreas makes for the digestive tract. Should never appear in the blood. All right. So esophageal varices may develop as a complication of liver disease. We talked about that. Pathophysiologically, this condition is attributed to which of those things? All right, split between A and D. So the correct answer there is portal hypertension. So esophageal varices are those big dilated veins around the esophagus, and they get like that because in liver disease, blood has a hard time getting through the liver. So it backs up in front of the liver and causes all of the veins of the digestive tract to get kind of big and boggy and fragile. So I talked about esophageal varices because it's a leading killer of patients with liver disease like cirrhosis. Classic board question is patient presents to the ER in shock, vomiting blood, and has a history of alcoholism. What happened? He had an upper GI bleed because he had esophageal varices and an ulcer. So basically, an already dilated blood vessel started bleeding into his stomach. And oftentimes these patients die before they even get to the hospital. Elevated bilirubin. Yes, you see that in liver disease, but it has nothing to do with esophageal varices. It has to do with the liver not keeping up with bile production because it's sick. All right, so we're going to stop right there for tonight. I will email you all because I'm going to post, when I've posted the shortened versions, number one, and then to find out about that December 5th, how many people are in favor of that for our final instead.